This patient was referred to me for endodontic treatment of tooth number 2. Now, when I post a case like this, I have some followers who make a comment that this tooth and this tooth both should have been extracted, and perhaps maybe tooth number 4, an implant, dental implant, or partial denture, or what have you placed. Well, your opinion really doesn't matter. What matters is the dentist, the patient's general dentist's opinion, that matters. Patient's endodontist opinion, that matters. And of course, the decision that the patient themselves make, that matter. So your opinion really doesn't matter here. So don't make a comment that this should have been done this way, or this tooth should have been extracted, or this should have been done that way. It's just your opinion, which again doesn't matter. There are two clinicians and the patient themselves are involved here, and they decide. The patient, most importantly, decides what is best for them. We present to the patient their options and prognosis for each option, and then the patient decides what they want to do. We're not talking to a 6-year-old here. The patient here, for example, this patient is 72 years old. So our job as the patient's doctors is not to tell the patient either my way or the highway. We present each option, each choice to the patient. We go over the prognosis for each option, and then patient decides what's best for them. What's best for them, not what's best for you. The person a few hundred miles or a few thousand miles away inserting your opinion into something that has nothing to do with you. Also, the other thing that I want to talk about is that we only comprehend things as far as our knowledge and experience goes on that subject. So if you are a new dentist and you don't know how to restore a tooth like this or how to restore a tooth like this because you don't know how to do it, so your inclination is to extract these teeth because, again, you don't know how to restore them, so you take the easy way out. So you could convince your patient to extract these teeth when these teeth are easily restorable for a experienced, knowledgeable general dentist other than you. So that's another thing that you need to consider. So to you, because you don't have the knowledge and experience to restore a tooth like this or like this, then you say extract because you don't know how to restore a tooth like this or a tooth like this. All right? So anyways, I wanted to clarify that first. So we discussed options with the patient. The patient had already spoken with his dentist. Again, this patient is 72 years old. And the patient and the dentist had decided that they wanted to save both teeth. This tooth has had a root canal before, and the root canal is fine. We don't have to redo the root canal here. The patient's dentist will just clean out the decay, remove the old crown, clean out the decay, and rebuild the tooth and put a new crown on it. And here, the dentist and the patient's dentist and the patient himself, they wanted me to go ahead and do a root canal on this tooth because, again, this dentist is experienced and knows how to restore a tooth like this. And that's what we did. So we went ahead and did the root canal for this patient. So let's take a look. Went through the crown, cleaned out the decay, rebuilt the missing walls, and take a look at the endo. And here it is. Look at that beautiful curvature of the MB root. So as you can see, we did our part. Everything went beautifully. We referred the patient back to his dentist for the permanent restoration. Now, if I did not have the 4 years follow-up of this tooth, some of you would have said, oh, yeah, whatever, should have pulled it, what have you. But I actually did this root canal 4 years ago. And here's the date. And this is today's date. So as you can see, 4 years ago. So now let's go ahead and look at the 4 years follow-up of this tooth. To those who said the tooth should have been extracted, this patient has had this tooth in his mouth along with tooth number 3 for the past 4 years with no issues and no problems. For those who, again, who would say these teeth should have been extracted. Here it is. 4 years post-op of tooth number 2. Tooth number 3, you can also see that the tooth is restored beautifully. And look at tooth number 2. The dentist, patient's dentist, was able to restore this tooth, put a new crown on it. Tooth number 3 is same, put a new crown on it. And as you can see, this is 4 years follow-up of tooth number 2. Tooth is doing beautifully. So this patient, if he had a dentist like you, and by you I mean the people who say extract, he would have lost a couple of really good teeth. But now he's had these 2 teeth in his mouth for the past 4 years. Again, remember, this patient is 72 years old. So simple root canal, build up, crown, another build up and crown here, and he's had these 2 teeth in his mouth for the past 4 years, and he's going to continue to have these teeth in his mouth for the past many years. As long as his oral hygiene is good, because the problem was his oral hygiene wasn't good, but now he's motivated. He said he bought a water pick. Also, he flosses and brushes properly. So no reason for these restorations to fail or root canal to fail, and he's going to have these teeth in his mouth for the probably rest of his life. Again, remember, he's 72 years old. All right, and here's the date. 3/4/2025, when I saw him for his 4-year post-op, and this is today's date, okay? So now, it wasn't surprising to me that the patient came back with the same problem on the upper left side this time. Take a look. Same exact problem, unfortunately. Tooth number 14 has had a root canal before, recurrent caries under the crown here, and look at tooth number 15. Same pattern of decay. And again, patient himself and his dentist both wanted to try to save both of these teeth. So number 14, we don't have to redo the root canal. The dentist will just cut the crown off, clean out the decay, and rebuild the tooth and put a new crown on it. And the patient and the dentist both wanted me to go ahead and endo number 15. All right? Just like what we did with tooth number 2. So again, this patient is 72 years old. It's not a 5-year-old who cannot make decisions for themselves. So your opinion, it only goes as far as your knowledge and your experience restoring these teeth or endo treatment of these teeth. If you don't have the knowledge and the experience to endo treat this tooth and then later build it up and restore it, your inclination is extraction. Because that's a cop-out. That's to take the easy way out. Because that's what you're comfortable with. So that's why your opinion really doesn't matter here. What matters is the opinion of what the patient wants. Once we go over their options with them, the prognosis for each option with them, and then the patient's dentist how capable they are, how knowledgeable they are restoring these teeth. And I go over the same stuff with the patient also. I also go over the prognosis, extraction, or endo, all of that with the patient again. And we go from there. And again, this patient decided that they wanted to try to save this tooth also. And they said, remember, you did a root canal on the upper right side for me 4 years ago? I made the right choice. That's what the patient said. I've had these teeth in my mouth for the past 4 years. I'm motivated. I'm going to floss and brush and what have you. A water pick and go ahead and do a root canal on tooth number 15. So let's go ahead and look at the POV. I have a POV clinical video of endo treatment for this tooth. So let's go ahead and see how I did this root canal for this patient clinically. Topical. My assistant is placing the topical. So let's fast forward. Tooth number 15. Local anesthetic goes in, lidocaine, buccal infiltration, and I always give a palatal injection also. Local anesthetic is given slowly, and yes, with the upper, you also aspirate, as you can see here. I'm going to give one more lido buccal infiltration, and then a couple of mils remaining at the end. I administer that in the palatal, just to make sure that the patient is comfortable with the rubber dam clamp. That rubber dam clamp can pinch the gingiva towards the palatal and could be painful. All right, so palatal infiltration, injection, very slowly, just a few drops, to make sure that the rubber dam clamp doesn't hurt the patient. All right, rubber dam goes on, clamp first. And here, as you can see, I'm using a premolar clamp for upper left second molar. So you can grab the tooth better, the smaller profile. So you can grab the tooth better. I can have a better isolation. Patient was telling me that perhaps maybe he wasn't feeling numb enough. So I believe the patient. I won't tell the patient, oh, I just gave you a carpal and a half. There's no way that you could feel it. None of that stuff. I definitely give the patient, I believe the patient. I give him a couple of more cc's of local anesthetic. We want to make sure a patient is comfortable. All right, rubber dam. and a bite block, just to help us out and also help the patient out. Again, patient is 72 years old, so the jaw gets really tired at that age, you know. It's hard for a 72-year-old to try to keep their mouth open for 30, 35 minutes, 40 minutes, whatever this endo treatment will take. Making sure that the clamp is stable. Now what my assistant will do is she will suction around the tooth and then wipe the tooth down with 70% isopropyl alcohol, the tooth and the rubber dam clamp and rubber dam and what have you. All of that gets wiped down with 70% isopropyl alcohol. I just didn't like the location. Oh, well, patient I think was saying that he was still feeling it. So I said, okay, fine. That's fine. We'll give you more local anesthetic. So there you go. Now I'm giving almost like a PDL injection. And I'm using Septocaine here. As you can see, the pressure, the force I'm applying to the syringe, it's a PDL injection, so it requires some force. I'm using Septocaine here. Again, no point arguing with the patient. If the patient says that they're feeling it, they're feeling it. So the patient's not going to lie to you. The patient doesn't want to make your life miserable and complain. It's not a complaint. Patient is feeling it, so we're going to give him some more. It's not like there's a shortage of local anesthetic. So let's just go ahead and give the patient a few more cc's of local anesthetic, buccally and palatally. Sometimes the bone density is different in the maxilla. Bone density could be a little bit thicker and you're giving a infiltration. So this time I gave Septocaine, which will penetrate through the bone at a much better rate. All right. Let's see what I'm going to do next. All right. Rubber dam clamp goes back on. Again, patient comfort, I can't emphasize on how important patient comfort is. You make the patient as comfortable as possible. I mean, the patient's still getting a root canal, but that doesn't mean that the patient needs to be tortured while getting a root canal. You just make him as comfortable as possible. I always tell my patients, you're not at Disneyland here. Don't expect Disneyland entertainment. You're getting a root canal. I'm going to make sure that you're as comfortable as possible. All right, my assistant is wiping down the rubber dam clamp, and the tooth itself with 70% isopropyl alcohol. And finally, I guess, let's go ahead and get started. So this is what we have. You can see the MO caries right there on tooth number 15, upper left, second molar. I moved the rubber dam a little bit towards the mesial so I can have nice direct access to this tooth and decay. And let's go ahead and get started. I don't use water because I know how to use my high-speed handpiece properly, and also I have better vision without the water. Also, I'm doing a root canal. That means I don't care what happens to the pulp. I'm removing the pulp, but you need to be careful not to fry the periodontal ligament. If you don't know how to use the high-speed handpiece without water properly, then use water. All right, so let's go ahead and remove the bulk of the decay here with our high-speed handpiece. That's a end-cutting diamond burr, cylindrical diamond burr. My assistant to the left is suctioning. My assistant to the right is blowing air on the mirror. 6-handed endodontics. You see all the decay. I'm just trying to remove the bulk of the decay and remove as little as dentin, healthy dentin as possible. Because again, this tooth is compromised, so every little bit of dentin that we leave behind can help the dentist restore this tooth properly. All right. Here we go. Just very carefully, taking my time, not rushing anything. I schedule one patient at a time. So that way I don't have to get up in between patients and lose track of what I'm doing while the poor patient has their mouth open for half an hour waiting for me. I don't do that. One patient at a time. One patient comes in, gets treated, leaves, the next patient comes in. So I don't get up in between patients. I have one patient at a time. And again, if you disagree with me on how I do certain things a certain way, that's fine. That's okay. Just do it properly, but do it your way. It's like there are many ways to go from your house to your parents' house. You can take your car, you can take the bus, you can take a ride on your bicycle if they're close by. You can, if you have a motorcycle, drive your motorcycle. You end up at your parents' house regardless. So this is the same thing. As long as you end up at the end doing the root canal properly, following the fundamentals of endodontics, it doesn't matter how you do it. You do it your way. This is how I do it. You don't have to do it exactly like me, or if I don't do it exactly the way you do it, that means that I'm doing something wrong. I'm posting these for you to just get an idea, to see how I do it. If you can get something out of it, fine. If not, you think you can do better, or there's another way that works better for you, so be it. Do it your way. So I'm using my Endo Explorer to just get a feel, remove all the debris, make sure that I cleaned out all the decay. You can see the gingiva there. There's some gingival bleeding, as you can see right there. All right, so I'm using Cutrol. Is a hemostatic agent. I really like it. It's 30% ferric sulfate solution. And I'm just trying to see if I can stop the bleeding. And it looks like I was able to. And here I'm putting duotemp. Duotemp has, remember the old IRM powder and liquid that we used to mix? This is kind of like that, is pre-mixed and is dual cured. So as you can see, I just rebuilt that mesial wall temporarily with duotemp. Doesn't have to be perfect as long as it's sealed, because after I do the root canal, I refer the patient back to the dentist, just like what we did with the second molar on the upper right side. And the dentist will restore this mesial wall properly and permanently when he is building the tooth up and prepping it for a crown, just like what happened with the tooth on the upper right side, that second molar on the upper right side. All right. So making sure that that mesial wall is there and it's sealed. We need 4 sealed pulp chamber walls. So let's just go ahead and cure it. Remember, it's dual cured, so we can go ahead and cure it for faster setting. See, these are all steps that are important. I haven't even started the root canal yet. Now I'm reinforcing my duotemp with flowable composite, just to make sure that it doesn't come out in the middle of the endo. So that's a trick that I've come up with, and it works for me. Again, the point of this video is not for you to make a comment and criticize how I do it. This is how I do it. If you take it, if you watch this and you think, okay, it's better than your way, then adapt it and adopt it. Adapt it to you and adopt it. But if you think that no, your way is better, you don't need to criticize the way I do it. Just do it your way. Again, there are many ways to go from your house to your parents' house. It doesn't have to be one way and that's the only way. You have many options. Same here. So there are many options. As long as the root canal gets done properly, without any contamination of saliva and blood and bacteria from the patient's mouth and what have you, you have sealed pulp chamber walls, and you do the root canal properly by the book, adhering to the fundamentals of endodontics, then it doesn't matter how it gets done. I do it. This is how I do it. So let's go ahead and clean things up and make our endo access. This is a round cutting, cylindrical diamond burr. Just taking my time, brushing with the diamond burr, trying to unroof the pulp chamber slowly. And looks like we're through. One assistant is suctioning, the other assistant to my right is blowing air on my mirror. Very nice. Okay. I still have a little bit more cleanup to do. I got the distal buccal right there. That's the distal buccal. That's the MB. That's the palatal right there. And that's the pulp tissue right out of the palatal canal. Stubborn. You see how stubborn the pulp tissue is. It's going to become fibrotic because of the chronic decay. All right. So I asked my assistant to give me a thinner end cutting diamond burr. And we're just going to clean everything up nicely. Remove some of that dentin. If there's an MB2, we'll find it. Remember, that tooth number 2, upper right second molar, didn't have an MB2. So it's very likely that this tooth also doesn't have an MB2, but we'll see. I'm not going to assume that it doesn't have it just because the other tooth didn't have it. I'm going to verify. So these upper second molars, according to Pomeranz and Fischelberg, they have 3 canals 60% of the time, and of course 4 canals 40% of the time. All right. That's the MB, DB, and palatal right there. And you can see how nice and clean everything is. All right. So let's go in with our reciprocating handpiece, M4 safety handpiece, which is a reciprocating handpiece. That's a 08C file attached to my reciprocating handpiece. No hypo or anything right now. I'm just scouting and exploring. I'm running the reciprocating handpiece at 1000 RPM with the torque off. I don't need the torque on here. It's a reciprocating handpiece. Just scouting the canals, making sure we can go to our estimated working length, and we could in all canals. So this is a 6% hypo right now, irrigating the canals and pulp chamber with 6% hypo right now. You can see how nice and sealed the pulp chamber is, where we can actually leave hypo, keep the pulp chamber and canals filled with hypo. If we didn't have that mesial wall, we wouldn't be able to do this. Hypo would get all over the place, cause gingival bleeding, get inside of the patient's mouth. You have bleeding, gingival bleeding that you have to worry about, and all kinds of other issues, contamination, and patient was unhappy and uncomfortable because they were tasting hypo in their mouths. So See how much easier that is right now? So that's why it's so important to always rebuild the missing walls before you start the root canal treatment. All right? Pay attention to how I'm using these C files. I believe this is a 10C file now attached to my reciprocating handpiece. Up and down in a brushing motion. Look at what my assistant is doing. My assistant just used 70% isopropyl alcohol to clean around the tooth. Again, we're all OCD. I didn't even ask my assistant to do that, and she did it by herself. She pays attention to everything I do. So again, 6% hypo. Very nice. We can now go ahead and take a measurement, get our working lengths. So my assistant just blew a little bit of air in the pulp chamber to get rid of the hypo, so there's no shorting of the apex locator. There's still a little bit of hypo in the canals though. All right, let's go to the next video. All right, let's get our measurement here. This is a 25 millimeter C file, number 10. And I'm using the Fine Pex apex locator by 8 teeth. Let's get our measurement here. All right, let's see what the palatal measurement is. All right. We got our measurements. We got our working lengths. Now 6% hypo again. You can see the pulp chamber is filled with hypo. If you didn't have that mesial wall, you couldn't have done that. All right, now that we know our working lengths, let's just go ahead and get our glide path going. This is a 10C file attached to my reciprocating handpiece, running at 1000 RPM with the torque off. I'm not only instrumenting and shaping the canals with it, you see how I'm using it, brushing with it. I'm also activating sonically the 6% hypo with the same device. Distal buccal now. My assistant wipes down the file and let's go into the distal buccal canal to our working length that we got from the Fine Pex apex locator by 8 teeth. Just pay attention to my hand movement, how I'm using these files that are attached to my M4 safety handpiece, which is a reciprocating handpiece that I'm running at 1000 RPM with the torque off. I swear, I say this so many times and still have people telling me, Dr. Nazeri, what is that? What's the RPM and torque? Like, oh man, I've said it like 50 times during the root canal treatment. All right, irrigating again with 6% hypo. Look how nice and clean everything is. No bleeding, gingival bleeding, no contamination, nothing. All right, so this is my number 20 flare file. Where do I buy the flare file from? I buy these flare files from Manny. So the flare file is just like a K file, but instead of having a 2% taper, it's got a 5% taper. And it's called a flare file because you flare the canals with it. You don't have to take it all the way to working length. If it wants to go to working length without you forcing it, go ahead, but don't force it. The point of the flare file is to flare the canals with it, and preferably you flare the canals in the coronal to midsection of the canal. But again, if the canal is wide enough and this flare file wants to go to your working length, then without you forcing it, then let it. But the point is to brush with it and flare the coronal to mid of the canal with this file. Again, it's attached to my reciprocating handpiece. So it's reciprocating. This is called reciprocation. So it's not turning like this, it's reciprocating, back and forth, back and forth. So that's how it cuts. Again, copious irrigation with 6% hypo. Pay attention to how I'm using this syringe irrigation. I got an irrigation tip. So it's a side vented tip. All right, so I'm recapitulating right now with my, I believe it was a number 15 C file. And I recapitulated, and the recapitulation is going about maybe 0.5 millimeter longer than your working length. So it's slightly longer than your working length to ensure that you didn't pile up debris in the apical area of the canals and block yourself. Again, going back in with a number 15 C file again to my working length, because that flare file produces a lot of debris. So the last thing you want to do is to block yourself with debris. All right, so again, 6% hypo. All right, very nice. All right, I'm using the Easy Shaper files designed by my friend, Dr. Kalantar. I'm pointing to his signature here on each packet. These are great files. For these types of root canals, because the canals are very thin, so you want to maintain as much denting as possible. You don't want to over instrument and over taper, over shape. So these Easy Shaper files, they're great files for these types of canals. They're very resistant to fracturing also. Of course, as long as you know how to use them properly. I created a glide path with all the previous files that I used. I'm running these files, these NiTi files. These are heat-treated NiTi files. I'm running them at 350, the RPM. I'm in the distal buccal right now. Very good. All right, let's go ahead and irrigate again with 6% hypo. Again, this is how I do it. You don't have to do it the way I do it. Just get an idea of how I do it, and this works for me. Next file. Mesiobuccal, so there was no MB2. So it worked out just like the other tooth that we worked on 4 years ago, tooth number 2. All right. Every time I remove the file, my assistant wipes it down to get rid of the debris. Because if the flutes of the file are filled with particles and debris, you're just burnishing the canals. You're not cutting. The flutes need to be void of debris for the file to be able to cut. So make sure that you clean the flutes of your file after each use, so before you go put it into another canal. See, did you see how much cutting? The flutes were filled with debris. All right, 6% hypo again. Very good. All right, let's try to see if we can cone fit. This is just a number 20 gutta-percha cone, 4% taper, 4 to 5% taper. The taper of these files, of these gutta-percha cones is not like 100%. It's between 4 to 5%. And remember, I brush with my files. When I brush with my files, you think that you think the taper of my canal is the taper of the last file I used? No. What I just showed you here is before I put the gutta-percha cones in the canals, I had my assistant soak them in 6% hypo. So they were soaking in 6% hypo a few minutes before I placed them in the canals. All right, so that's what I was showing you. The gutta-percha cones being soaked in 6% hypo for a few minutes. That's kind of like cold sterilization of the gutta-percha cones. Because gutta-percha cones that you purchase, they come in packs, they're not sterile. And that, look, up and down, up and down, up and down. What I'm doing right now with the gutta-percha, master gutta-percha cones, is another way of activating the 6% hypo. So as I was saying, I'm not just, the taper of my canals is not the same as the taper of the last file I used. Why? Because I brush with all my files, I brush with them. So when you brush with your files, the taper is larger. Last irrigation is 70% isopropyl alcohol. and microsuction to remove the bulk of the 70% isopropyl alcohol from the canals. Do you see how nice and clean everything is? No saliva contamination, no blood contamination. Patient is comfortable. They got their bite block on. They're comfortable. My assistant suctions for them frequently just to make sure that they're comfortable. See how nice and clean everything is? All right, let's go ahead and dry the canals with sterile paper points. These are sterile paper points. I buy them sterile. I have some people who say, some clinicians, some followers say, how do I sterilize my paper points? I buy these. These are sterilized. So I don't know how you can sterilize your paper points. Perhaps, as I said, put them in autoclave pouches and put them in your autoclave and see if you can maybe sterilize them that way. All right. So you saw that there was some bleeding from the distal buccal canal. That's fine. No reason to panic. Sometimes there's a little bit of bleeding. So when that's the case, I always like to reconfirm my working length from the canal that was bleeding. And here the distal buccal canal was bleeding a little bit. So I asked my assistant, give me the apex locator again. Let me make sure that my working length is proper. We're just going to confirm it. My assistant is going to read it and tell me what the working length is, and if it's different from the initial working length that we got. All right, let's go ahead and use sterile paper point again. See if we can dry this canal. You don't want to obturate when the canal is bleeding. That's the last thing you want to do. Don't ever obturate a canal if the canal is bleeding. The bleeding must be stopped. So I'm just leaving the paper point in the canal just to apply some pressure to the periapical area of the canal. Just like if you're bleeding, you put pressure on it. Same concept. Another sterile paper point. And as you can see, the bleeding has almost stopped. I'm going to confirm it again. So my working length was correct. Just again, I can see some bleeding again. More sterile paper points. Again, I can see it bleed again. So now what I'm going to do is see, there's still bleeding. You see that? Right there. I'm not going to obturate it. Believe me. So let's just go ahead and let that distal buccal canal be. Let's focus on the other canals. Let's go ahead and obturate the MB canal and the palatal canal, and we'll go back to the distal buccal canal. Let's give it some time. So MB canal, palatal canal here. Let's just obturate these canals right now. See how OCD I am. Like I check the tip of the master gutta percha like 10 times just to make sure that it's not bent, It looks nice and straight. I got a good tug back. No shortcuts. All right, so this is my system B. We're going to cut the gutta percha and thermoplasticize the apical part of the gutta percha so we can use our number 2 Buchanan pluggers or condenser and press apical pressure, hold. These are great condensers. They're nickel titanium. Go ahead and condense the thermoplasticized gutta percha in the palatal canal. All right. Just clean everything up. I believe this is a number 1 Buchanan condenser now, plugger or condenser. Just making sure that I got a good seal. All right, very nice. All right, this is cut roll. So I dipped a sterile paper point in cut roll. Again, that's cut roll is 30% ferric sulfate solution. Let's see if we can stop the bleeding. And it looks like it stopped. Let's check again. See if it stopped. Yes, no more bleeding from the distal buccal canal. Now we have to irrigate it again because now we got what? Blood clot on the canal walls. So we need to go back in with 6% hypo and get rid of all the dried up blood clot attached to the canal walls. Just irrigate it again with 6% hypo. All right, very good. Very nice. Microsuction. Very good. Let's see if it's dry. Paper point, sterile paper point to working length. Let's dry it a little bit more. And voila. We can go ahead and obturate now. There you go. If it was bleeding, you would see blood coming up. And if I saw that, if I saw blood mixed with my AH plus sealer, I would pull everything out and try to stop the bleeding again. That's one of the advantages of having a surgical operating microscope. It magnifies everything. All right, so number 2 Buchanan plugger or condenser. I'm going back with the number 1 now. Apply some apical pressure, just like that. Very good. All right, let's backfill with our Obtura gun. And we're going to condense again. And that's it. We're pretty much done. What I'm going to do next, following this, is I'm going to use 70% isopropyl alcohol to clean all the extra AH plus sealer, gutta percha, what have you. Make sure that the pulp chamber is nice and clean. Then place sterile sponge in the pulp chamber and cave it. And that's it. Remove the rubber dam. Then the girls will take some radiographs, and that's it. We're done. Patient's going back to his dentist, so his dentist can do exactly what the dentist did for the upper right side, those two teeth on the upper right side. All right, so that is 70% isopropyl alcohol that I'm going to use to clean the pulp chamber, floor and walls. Make sure everything is nice and clean. Blow some air. Dry it. All right, very good. Look how nice and clean everything is. And sterile sponge and cave it. Sterile sponge. See, I'm constantly inspecting just to make sure, up to the last minute. All right, sterile sponge and cave it, and that's basically it. So, and then rubber dam comes off. So let's go ahead and take a look at the post-op video, post-op radiographs. And here's the post-op. So as you can see, everything went beautifully. And this patient is good to go. We referred the patient back to his dentist. And as I said, his dentist will do exactly what he did 4 years ago when we did a root canal on tooth number 2. He's going to build a tooth up and crown it. And hopefully this patient, 72-year-old, will have these teeth in his mouth for the rest of his life. Again, it all depends on his oral hygiene and home care. But we did what we had set out to do. We achieved our goal perfectly, textbook, adhering to every single step of the fundamental of endodontics. And as you can see, the outcome is beautiful. All right. So hope you like these videos. If you like these videos, make sure you subscribe. You've subscribed. Make sure you press that like button. Make sure you make a comment and share. Tell your friends about our channel. So let's spread the knowledge. Remember, I'm doing all of this for free. So all of this time I'm putting in, I'm just doing it for free, because all of the knowledge that I've gained, the experience that I've gained in the past 24 years, it would be a waste if I don't pass it on. So that's my way of passing on all the knowledge and experience that I've gained in the past 24 years. All right. So have a great day or night, and see you guys in the next video. Bye-bye.